Now, you're used to discharging patients home on oxygen with different types of devices, and I thought we would review some of the indications for home oxygen therapy, what some of the rules and regulations are for that, and talk somewhat about the different appliances that we use to deliver oxygen to patients. That basically, you guys see a lot on the floors when you're taking care of patients. You'll go into a patient room, sometimes you'll see things in the nostrils, sometimes you see a mask over the face, sometimes you see a mask with a bag, and it's probably good that you know exactly how all these different devices work, and where you might use one and use another. So I brought a little sampling of the different types of devices that you run into on the wards, and I'll pass them around. But first, I thought I would just go over a couple of basic principles about treating acute hypoxemia. And again, what I'll be talking about most of the time is what do you do with your chronically hypoxic patients. But in the acute care setting, you often will order oxygen. And these are just some of the indications: obviously cardiac respiratory arrest. If you have someone with a PO2 of less than 60, hypotensive, certainly if they're cyanotic. If they have low cardiac output, metabolic acidosis, or if they appear to be in respiratory distress, usually you just don't think twice, you give people oxygen. What I also want to remind you is that if you do have someone with COPD who is hypoxic and you're concerned about CO2 retention, you're not supposed to withhold oxygen if you're hypercapnic ventilatory failure. So you want to make sure your first priority is to raise their PO2 above 60, or to raise their oxygen saturation above 90%. And if they are, by any chance, relying on their hypoxic drive to breathe, you deal with the consequences of that later. So if their CO2 goes up to the point where they need ventilatory assistance, then you can do either non-invasive mechanical ventilation, or if need be, you can intubate somebody. And just as an aside, if you're concerned about CO2 retention, obviously you'll measure blood gas. And what sort of limits do you like to place on your blood gas interpretation, in particular the pH and PCO2, where you would really start to get worried about either intubating a patient with COPD or starting them on non-invasive mechanical ventilation? So, what type of pH? Are you worried when it's down to 7.25? You start getting concerned. And certainly if it's, but usually you can get by in someone with COPD if their pH will drop to 7.2 to 7.3. If it's less than 7.2, you're going to have to intubate them. But in terms of titrating your oxygen, you do have to give yourself a little leeway with the pH. And 7.2 to 7.3 is a good place to gray area there. And if you do have someone in that situation, you don't necessarily have to intubate them, but you certainly should monitor them carefully with repeat blood gas. So if you have a patient with COPD and you want to give them oxygen, what's the usual mode of administration that you use for your patients? Nasal cannula. Exactly. So let's see if I have any of those in this bag. Well, I don't have a nasal cannula. So, but we can go next door and get one. I'm sure you all know what that is. And when you order the nasal cannula, how do you order it?
oxygen at a certain amount of liters by nasal cannula.
Okay, so basically you give it's a prescription. Anyone else need to read? So it's a prescription for oxygen, so you need to usually prescribe a liter flow per minute. And if you're starting, and usually how many liters per minute can you do you need to give? Generally, again, with your COPD patients, you can get by with giving a very low flow, 1 or 2 liters per minute. And usually if you have your oximeter, you can monitor oxygen saturation and, again, assure that you get to your target somewhere between 88 and 90% saturation, 92% saturation. And why is it that these patients with COPD respond to such low levels of oxygen that you're giving them? You think about the causes of hypoxemia. One of them that they have, if you have your shunts and your diffusion impairment, you have your hypoventilation, and of course the most common one is your ventilation-perfusion mismatch. So your patients with COPD, the underlying lung disease, the cause of the hypoxemia is primarily DQ mismatch. And so with that, small concentrations of oxygen give a great benefit, so that all you need to do is give 1 or 2 liters per minute, and that's usually enough to get sufficient oxygen into the alveoli to cause whatever alveoli is being perfused. It has a low ventilation, but it still has ventilation, so if you can enrich the oxygen content in that alveolus, then you will raise their VO2. So typically we start off with nasal cannula, nasal prongs, and if you find that you need to give a little bit more oxygen, or you're worried that they're starting to retain CO2, what's sort of the next oxygen system that you use? So there's a difference between a simple face mask and a venting mask. And you know which one you can really refine your oxygen? So the venti mask works a little bit better. And here we have a venti mask. So it comes with a nice little adapter. And I will pass it around so you guys can look at it. And it comes with different colors, different colored adapters. So if you order oxygen, you can order by your favorite color, but that's probably not the best way to do it. Each color, do you know why they're color coded? Yeah, they have different concentrations, and if you want to know what each one is, you read on the bottom here. For example, this one is set for 35% oxygen at a flow rate of 12 liters per minute. So in theory, you can fine-tune your oxygen concentration that you're delivering to the patient by ordering a venti mask system. So if you're worried about CO2 retention in a patient with COPD and you want to be very precise about how much oxygen you're giving them, the best thing to do is to order a venti mask. And usually you start off with a low concentration of 24%, 28%, 35%. And these venti masks can go up to about 50 or 60% oxygen concentration. And I'll pass this bag around also for you to look at. And the way this device works is, if you notice that each one of these colored inserts have a different diameter orifice in them. And so when you set the flow meter delivering oxygen at a certain rate, the flow goes through the orifice, the narrow orifice, and what happens is it entrains, it lowers the pressure around the orifice. And so if you're, the higher the flow rate, the Venturi principle of Bernoulli effect, you lower the pressure around the flow. So the higher the flow rate, the more air you entrain from the room, and the lower the FiO2. So if you notice the different holes, the smallest diameters will actually give you the lowest concentration of oxygen, and the bigger diameters will give you the higher concentrations of oxygen. So that's a good way to titrate oxygen for your patient with COPD. What happens is you have your patient with COPD and respiratory distress, you order nasal cannula, the therapist comes to you and says, well, you know, he's looks like he's still in respiratory distress, his breathing is getting a little more shallow, what should I do next? Say, well, I know, you'll put a venti mask on and I'll choose 35% oxygen. So you get one of those colored orifices, you treat the patient. A few hours later, the respiratory therapist comes by and says, well, I just measured his oxygen saturation and you know, he's down to 75% sat. What should I do next? Well, the first thing you think of is, well, there must be something odd going on here, because I know COPD is a disease which is primarily ventilation-perfusion mismatch. Therefore, all I need to do is give a little oxygen and their PO2 will come up. I'm giving this guy 35% oxygen and he's hypoxic, so there's got to be something else happening here. And the two things that come to mind are... No, I'm just still talking physiology. PE always comes to mind. So the two things that come to mind are hypoventilation. You know, is this guy starting to retain CO2, and is that why his oxygen is going down and his CO2 is not coming up? Or does he have a shunt? Has he developed a shunt? And most commonly, you might consider a shunt, whether it be from PE or pneumonia or atelectasis. And so now you're saying, well, low flow oxygen's not working in this patient. He's still breathing, but I need to improve his oxygenation. So now you've gone from the nasal cannula to the venti mask, and what's your next choice?
I'm
sorry.
Another breathing mask.
A breathing mask. What kind of breathing mask?
It's not a breathing mask.
Okay. Let's see if we have one. Is this what you mean? No. This is just a humidifier. So if you want to pass that one around. We can talk about humidification a little bit later. How about this guy? Want to use this guy? Well, this is kind of like a venti mask, and you can set different concentrations of oxygen on this by moving this dial. And again, there's what happens is there's a flow of oxygen at a set rate that will go into the top of this valve, and this little spinning valve on the top allows more or less air to be entrained from the room. And so you set it at a flow rate, and then you put the orifice where you want it, and that will give you the oxygen. So I'll let you guys take a look at that. So if you want to use that device, you can use it with a mask. But is this the mask that you were looking for? This is sort of for someone who's claustrophobic, and doesn't like masks, you can sort of put it under the chin and give oxygen that way. But this is more of the mask that we were talking about. And with this mask, you can deliver higher concentrations of oxygen, probably 60–70% FiO2. Now, how does this one work here? Usually you'll see the respiratory therapist set it up. So there's a flow that comes in, it fills up the bag, and what the therapist will do is they'll watch to make sure that the bag doesn't empty completely with each breath. So there is I'll pass this around also, but there's a one-way valve here which allows someone to inhale from the bag, but the exhalation goes through these little holes here. So they're just inhaling from the bag. So that when this is full, there's like a reservoir here. So you can breathe 100% oxygen. So with a reservoir that equals your tidal volume, this mask will be deliver close to 70–80% oxygen. So this is a good choice for someone who you really want to give oxygen to.
So venti mask will deliver oxygen up to 50%. How much?
Yeah, the venti masks, usually the maximum on that is about 50%, 55%. These will give you more oxygen. So if you really need to give someone more oxygen, you put them on a reservoir mask, and then obviously check your saturation afterwards. So the key there is it's a one-way valve system with a reservoir, so that they're inhaling a volume of oxygen rather than just a flow.
And is this what we call the face mask as well? Non-breather, in loose form, or the venti mask is called face mask?
The venti mask is called a venti mask.
Venti mask.
And
And this,
this one is called a non-rebreathing face mask.
and so where does the face mask fit? These two?
You need to explain what you asked, because usually when the nurses are treating us, they tell us, oh, we're doing on the nasal canal, and now it's on the face mask. That's why he's asking which one is the face mask. They
This
mean
is a face mask. A face mask is sort of a general broad term. You can wear it on Halloween. But you should find out, the easiest thing to do is just put something on a face mask. This one, they've taken out the valves, and so you're going to drain a lot of air from the room when you're breathing with this. But if you want to give a lot of oxygen, you need to use one with a bag, or a reservoir bag. And that's often called a non-rebreathing mask, so that you're inhaling from the bag and you're exhaling out of the room. Usually they also have some valves on that too. Those don't have the valves on them. Yeah, this one has a valve. Here we go. So this is another reservoir, non-rebreather, and this has the valve in place. This is a plastic one. It's a flat valve. You can see how fragile they are and they come off easily, so if you have a patient that's pretty fidgety, they might change it. But you want to take a look at the valve.
Do these bags come in different tidal volumes, or it's just a set volume?
That can be set to the patient. So what the therapist will do is they'll stand there, they'll they'll turn the oxygen on, fill up the bag, and they will make sure that when the patient's breathing, the bag doesn't completely collapse. So they'll set the flow rate so that it stays inflated. Of course, if the patient changes the breathing respiratory rate, the breathing pattern, that the emptying of the bag will change too. So now you've sort of gone to the limits almost of what you can do on the floors with a patient trying to oxygenate. The respiratory therapist comes back and says, O2 sat won't budge. What should I do next? Well, so you call the ICU? But they say, We have no beds. You can intubate, but if the patient says, I'm not ready to be tubed yet, I'm still breathing on my own and I need more oxygen, you can add nasal cannula in there. So you can cut a hole in the mask, put the nasal cannula under, and then put the face mask over that, so delivering even more oxygen. But usually if they get to that point, you do have to call the ICU, and you do want to try non-invasive ventilation first, and if you need intubation. And so then the patient goes to the ICU. He's on the ventilator a long time, more than 2 weeks. He gets a tracheostomy, and finally weans and comes out to the floor, and then you see one of these gadgets. It's exactly the trach mask. And the only thing that, again, with this precaution is sometimes it'll slip. The patient may have a very back neck through the trach site or displace it. So this is sort of the, you've got to, with all of them, you want to make sure that they're working properly. And one thing, especially with the venting masks, is that you want to make sure that the orifice and the holes that are around it, in the training room area, are not covered by bed sheets or anything above a blanket or something like that. So those are some of the gadgets that you see on the floors and when you're seeing patients being treated with oxygen. Now you'll see other gadgets if you're taking care of your patients at home. So for example, the patient that we were just talking about is ready to get discharged from the hospital now. You're wondering if they need oxygen at home, so what do you do next? You send them over to pulmonary for an oxygen needs assessment. And so our technician calls you up and says, patient's oxygen saturation is 91% at rest, but as soon as I get him up to take 5 steps, he drops down to 87%. But I can correct that when I put oxygen on 2 liters per minute, is when he's walking, his oxygen saturation is good. So why do we go to all that bother to determine exactly the oxygen needs? Why don't we just send them home with oxygen at 2 liters per minute without any documentation?
It's going to affect the mortality of COPD patients. Once we put them on oxygen at home, how much hours we're getting back to.
And so you mentioned that it's a financial problem. You know how much oxygen costs at home?
Yes,
I know that they need to give us an idea.
There's one thing we try to do that, so that it's at least $30, but depends on how
$100 a month is cheap.
not just that, but it can go up to $10.
Usually about $300 a month for the different oxygen systems. So if you want somebody to pay that much money per month for someone to have oxygen, you have to make sure they need it. And so that's why we do this. And I'll go over the guidelines of exactly how we determine who needs oxygen. And the other reason is that you had mentioned it improves mortality. And it's really, since 1980, has been shown that oxygen is the one treatment for COPD that really has a pronounced effect on livelihood, mortality, morbidity, the whole 9 yards. It's very important. These people benefit greatly from oxygen if they need it. So Now you've discharged your patient home, and he is